the coronavirus produces an inflammatory response. This then activates the immune system and the production of antibodies to fight and kill the virus. Now, there seem to be some people who have minor symptoms of a cold and fairly vague symptoms because they've recognized the foreign protein, they've attacked it, and they've cleared it out the system. There are other people who seem to have a very large inflammatory response to the virus. Indeed, the virus may be killed off, but the inflammatory process carries on. And these are the patients who end up in intensive care with multi-organ failure. It showed that if you gave a glucocorticoid like dexamethasone, that you could quench the inflammatory response. And so this was the first, and to me, not that surprising trial that showed that steroids work in this condition, which caused great excitement, more excitement, in fact, than other drugs we had tried, which were purely antiviral. So it is not just killing the virus, it's quenching this inflammatory response that is fundamental. Another part of the recovery trial is tocilizumab, which is a drug against IL-6, interleukin-6, which we've mentioned previously. And this has shown that if people have admitted to hospital and they have simple oxygen treatment, but they're not actually that ill, they've got to be able to get into hospital, but not ill enough for intensive care, then tocilizumab doesn't work. The Remap Cap study, which I think we'll talk a bit about later, showed that if you got as far as intensive care, then that helped. And in the middle, there is this group of people who slide into trouble. They don't have this profound cytokine storm, so tocilizumab is of marginal, if any, benefit. So we're looking for patients who have a severe inflammatory response to the virus. They're the ones that deal with later drugs, and steroids is an example of that. So far, I think with the dexamethasone story, I think it's important that dexamethasone is one of the most active glucocorticoids with virtually zero mineralocorticoid effect. So I think if we're going to replace dexamethasone with something else, we would use something of a similar profile. And that's where methylprednisolone comes in. It's got a small amount of mineralocorticoid effect, but it is largely glucocorticoid. The difference is not as great as in Dex, but that would be the second choice. If you looked at hydrocortisone, which is a one-to-one effect, so the same amount of mineralocorticoid and glucocorticoid, that wouldn't be my first choice. Prednisolone also has a very profound glucocorticoid effect, and we could use that. And indeed, if supplies of dexamethasone were threatened or methylprednisolone were threatened, we might then go for hydrocortisone injection or prednisolone orally because they have glucocorticoid effects, which I think is key to this, in that it's not just something that raises blood sugars, it's something that quenches the inflammatory process, which is really our aim of this process. We've used a range of doses of dexamethasone for various inflammatory conditions. You know, we've gone as high as 32 milligrams in quenching brain tumor edema, for example. Often we use much smaller doses. 6 milligrams was chosen in the trial, so the evidence base is with 6 milligrams. Now, whether that's the optimal dose, I don't know. We haven't done the dose ranging studies to find this out. Some people have gone as high as 20 milligrams and said this is better, and maybe it is in quenching inflammation, but we must remember that these are powerful drugs which are upsetting the immune system deliberately in the primary event, but longer term, we may end up selecting out fungal infections and viral infections as a secondary event, which we want to avoid. So yes, we don't know the dose. We don't actually know the timing or the duration. 10 days was tried. In some people, that's enough. In others, it seems to be inadequate, and we go on either with more dexamethasone or convert to methylpred, which has been suggested as an alternative. So we don't know the duration. We don't really know whether 6 milligram is the ideal dose. I think I would point out that the nomenclature of the injection is a little confusing, and some might say it should be 6.6 milligrams of the injection simply because that's a whole ampoule. This would be my advocate, because nurses in full PPE trying to work out what fraction of 6.6 is 6 milligrams seems to be an unnecessary waste of effort. I'd rather the patient got the drug, a whole ampoule, and left it at that. I think the Remap Cap trial design was a creative, innovative answer to the fact that we needed to try lots of different agents. We didn't know much about the virus, and we needed some fast results. So most trials look at one drug, maybe 2 or 3, again, and compare it against placebo. But this study said, well, we've got lots of ideas here, we'll try them, and if they prove successful, we'll give them to more patients, and so on, so that we could get a statistical analysis that showed the best outcome. So there are about 9 different arms to Remap Cap. There was aspirin, there was antivirals, there was dexamethasone, hydroxychloroquine, azithromycin, colchicine, all sorts of things were tried. And what we discovered fairly early on was some of the exciting drugs like remdesivir, indeed, and antivirals didn't actually prove as effective as we had hoped. So we stopped recruiting to those arms. And that's quite interesting, because drugs we thought would knock out the virus, we thought would make people have shorter stay in ITU or never reach it at all. And what we found was if you got to intensive care, giving antivirals didn't actually seem that helpful, which plays to this story of the virus may be dead, but the patient has still got a profound inflammatory response, which we must quench. And dexamethasone was one of the candidates that, again, showed promise, so we gave it to more and more patients. And as time has gone on, so we have introduced new drugs like tocilizumab, anakinra, and sarilumab, which again proved to be effective in intensive care, but not necessarily outside of intensive care. Well, I think we can say that outside intensive care, we don't really know the full story, and we're still exploring it. Inside intensive care, giving antivirals doesn't necessarily shorten the length of stay, but giving drugs like steroids and tocilizumab, which quench the inflammatory response, seem to be the ones that show benefit. And it could be that these are patients who have a profound inflammatory response, which they're unable to quench. So we give them drugs to help them suppress their overactive immune system so that they can get better and avoid consequences of infection, such as edema and inflammation and fibrosis, which may be what long COVID is. There are a number of drugs which will be incorporated into the Remap Cap studies. We haven't said anything about ivermectin yet, but then that's an idea to explore. We have noticed that patients have low vitamin D levels, and it could be that the BAME cohort of people, particularly in the UK, in the Northern Hemisphere, don't get enough sunlight, and so their vitamin D levels of synthesis are lower than required. Or it could be that if we treat the low levels of vitamin D that we are seeing, that maybe that will improve it. And I think vitamin D will be an interesting story for the future.